Bismillahirrahmanirrahim. Welcome you all to today's regular weekly academic session of Oncology Club. As you know, we are doing this virtual academic program because we believe that COVID is creating a social distancing, but we can be kept ourselves connected by this type of academic initiative. So today we have our regular session that how should I treat my patients following evidence-based medicine. And now, you know, we are running the thoracic lung cancer session. And today, very important topics is role of surgery in lung cancer management and what oncologists need to know. Our today's faculty is Dr. Kazi Saiful Shakil. He is an associate professor of National Institute of Disease of Chest and Hospital. And he graduated from our Sir Salimullah Medical College. And he has done his master's in thoracic surgery and also done a clinical fellowship in NUH Singapore. He is a very bright, promising thoracic surgeon. I'm sure he will be enlightening us about the tips and roles of thoracic surgery in the management of lung cancer. We are having 3 overseas faculty. Abhishek already this guy is known to us. He is a interventional radiologist in Rajiv Gandhi Cancer Institute, Dr. Ullas Batra. No need to give an introduction. The senior consultant medical oncology of Rajiv Gandhi Cancer Institute, and our old but very persistent friend, John Conivier, who is with us from the very beginning. And as usual, we always start with the comment from our president and patron, Professor M.A. Hai, who is the president of Oncology Club. Now I request Professor M.A. Hai, sir, to formally start the programs.
Thank you, Dr. Kamal. Bismillahirrahmanirrahim. Assalamu alaikum, all the participants and faculty from home and abroad. Today we are going to have one lung session. Today's speaker is Dr. Kazi Saiful Islam, and our faculties are Dr. Abhishek Batra from India, Ullas Batra, Abhishek Bansal, Ullas Batra, and Dr. Conivier. Overseas. Without delay, I think we should start immediately. Kazi Saiful Islam start his lecture. Thank you all very much.
Thank you, sir. So just for a quick recap, the program is designed for 90 minutes. Presentation will be around 20 minutes. And then we will have some comments from our overseas colleague. And there will be a 30 minutes extensive question and answer session. Then we will have a case discussion based on the role of surgery. And there is a quiz. And then we will do the vote of thanks and wrap up. And our faculties are not only the foreign faculties, locally the presenter and other participants of the assistant professor are treated as faculty. All the postgraduate students and postgraduate physician below the level of assistant professor are treated as participants. We will appreciate the question will mainly come from the participants, and the faculty presenter will primarily answer and the faculties will be supplementing. And at the end, our overseas faculty will put their supplement. So this is all about the introduction, and this, we can go to our session. Now I am stopping my screen share and asking Dr. Kazi Saiful Islam Shakil to share the screen and start his presentation. Dr. Kazi Saiful Islam Shakil.
Thank you, sir. Good afternoon and assalamu alaikum. A warm welcome from Dhaka, Bangladesh. In today's presentation here, I thank the Oncology Club and the authorities who are involved for inviting me and giving me opportunity for this presentation. So my topic today is the role of surgery in the management of lung cancer. I am Dr. Kazi Saiful Islam Shakil, a thoracic surgeon. So treatment of lung cancer as a whole, in a brief, it can be surgery, it can be radiofrequency ablation, chemotherapy, radiation therapy, the newly invented targeted drug therapy, immunotherapy, and also some palliative procedures. So as a surgeon, I focus on surgery and palliative procedures. So as you know, surgery serves as the diagnosis for diagnosis, staging, and definitive management of the non-small cell lung cancer. Why I'm not mentioning small cell lung cancer, because mostly they are not inoperable. And treatment for stage 1 and 2 non-small cell lung cancer is straightway surgery for curative intention. And for 3A, there is a multimodality approach for surgery. And removal of the lobe is the standard resection involved with the tumor and systematic evaluation of ipsilateral, hilar, and mediastinal lymph nodes. And minimally invasive approaches are very common nowadays. So surgery depends on type of the lung cancer, as you all know, stage of the lung cancer, extent of resection, and whether the patient can tolerate the resection, which depends on patient's general condition, other conditions, as for the fitness of GA, comorbidities, and nutrition status. So grossly, two types of lung cancer, non-small cell and small cell. Generally operable non-small cell lung cancer 1 and 2, generally inoperable small cell lung cancers. So stages is determined by the tumor size and location, and involvement of lymph nodes and the location of the lymph nodes, and also, of course, distant metastasis. So this is the latest edition, the 8th edition of the AJCC tumor staging protocol, where I think you all know that the tumor size has been elaborated as T1A minimally invasive, then 1A, 1B, 1C, also T2A, T2B, and there's some minor adjustments as compared to the other the previous edition. So for diagnosis as well as for staging, we need many investigations. So they can be a chest X-ray for the initial study, and CT scan of the chest, of course, with IV contrast to see the mediastinal structures properly, and CT-guided FNAC or core biopsy needed for the primary diagnosis, ultrasonography, fiber optic bronchoscopy for extension, and CT of the other part like abdomen, brain, to see the metastasis, MRI, bone scan, FDG PET scan. These are the lymph node stations, as you all know, from 1 to 14 intrathoracic lymph nodes. This is more elaborated. So previously, in the 90s, there was a lymph node mapping, which is upgraded now by the ISLC, the International Association for Study of the Lung Cancer. So they have categorized a slightly different way, like the higher mediastinal lymph nodes, which were station 1R and 1L. They now included the low cervical, supraclavicular, and sternal nodes into this, and the others are almost okay as before. And you can see the single-digit lymph nodes are actually N2, and the double-digit lymph nodes are N1. But of course, the exception is if you have a supraclavicular or scalene lymph node, it should be falling under category N3. So these are the descriptions from the IASLC staging project. So procedure to evaluate lymph nodes. As you know, I mean, first of all, you have to assess the lesion itself, and the size in the maximum diameter you have to assess through CT scan or 3D imaging. But then you have to stage the lymph node status, because it depends a lot for the surgical decision to take whether there's an N2 involvement of the lymph nodes or N3 involvement of lymph nodes. So we can go for bronchoscopy or EBUS. A lecture we enjoyed last week from Professor Ali Hossain sir about EBUS and transbronchial needle aspiration. Then there are mediastenoscopies, direct mediastenoscopy or video mediastenoscopy. And for the surgeons, we do anterior mediastenotomy, which is the Chamberlain's procedure, and alternate FDG PET scan, whether you can see all the lymph nodes, whether they are lighting up or not. So this is EBUS DNA. And mediastenoscopy, you make an incision just above the sternal notch and make dissection and put your mediastenoscope through that there under GA, and you see the lymph nodes directly, especially subcarinal and paratracheal lymph nodes. So this is a picture here. So now the staging, as you all know, staging has been done by in this way. So T1 T1, T2A, T2B, and these are the, I mean, if you consider N0, N1 lymph nodes, then these 6 categories are surgically operable cases, and there are some other cases like T3 with N0, and then we'll discuss T3A later. So who gets the surgery? As I already said, stage 1A, 1B, 2A, 2B, and selective cases of stage 3A. Also, there are some surgical intervention that we can uh, um, restore to in stage 4A and also in small cell lung cancer nowadays. So these are the primary cases for upfront surgery here, stage 1A to 2B. And this is a small group, T3 with N1 node, which is also amenable to surgery. And this is another group, T4 with N0, N1, which can be, for which surgery can be done with in selective cases, and also with obviously surgical expertise. And then we'll discuss about some N2 disease, which also fall under T3A, stage 3A here. And also a small portion, mainly palliative surgery for stage 4A, which has single station extrathoracic metastasis. So stage 0 and NSSC is the one where the T is the carcinoma in situ, and there is no nodal or metastatic involvement. So in these cases, we can do a curable surgery even by very minimal sublobar resections. Stage 1 and 2, generally resection of the primary tumor is done in case of surgery with evaluation of the draining lymph nodes, lymph node basins in ipsilateral hilum and mediastinum. Like you have to take the hilar nodes and mediastinal nodes. If you, I mean, in these cases, stage 1 and 2, you know that N2 nodes are not involved, but you have to take sampling or some preferred dissection of the nodes with the lobectomy areas. So now stage 3A. So stage 3A is a heterogeneous class of people. So we have to treat them with multimodality approach. Like in a multimodality tumor board, we have to take decisions. Evaluation should be done on case basis. And tissue diagnosis is pertinent here because in stage 1 and 2, some of the surgeons and some of the studies, they suggest that a pre-treatment tissue diagnosis is not always necessary. But then in these cases, you need the tissue diagnosis and you focus on the mediastinal lymph nodes. So now among the T3A NSCLC, there is this small group T3N1 disease. So T3N1 disease, our goal is to do a N block R0 resection with negative resection margins. And then post-operative chemotherapy is recommended to reduce the risk of distant recurrence, which especially if for a post-operative chemotherapy, and then overall survival is maybe as high as 50%. In some studies, here is a study, it's the results of surgical treatment in patients with stage 3 and non-small cell lung cancer done by Watanabe and his team. And post-operative radiation is reserved for patients in whom there is concern regarding the completeness of resection. And as I was mentioning, post-operative chemotherapy is mainly targeted for lesions more than 5 centimeters in diameter. And now another stage 3A NSCLC group who are T4N0 and T4N1. So here the tumor is very big. So if it is involving an individual structure, like we know it can involve the great vessels, the mediastinal structures. So if it is involving an individual structure, then surgery may be considered because in all cases we need a R0 resection. So the structure that involves in the mediastinal area or in diaphragm, you have to make sure that you resect the particular structure in question. Otherwise, R0 resection will not be achieved, and the long-term result will not be good. So tumors with invasion of the vertebral body may require orthopedic stabilization, and there are other studies, which is not a large randomized trial, but they have shown smaller studies where trachea carina have been described, resection of trachea carina has been described with acceptable outcomes. Michel and his team and T4 tumors invading the heart or great vessels has been also resected, and in a smaller series, giving up to 30 to 40% survival rates by Pitts et al. And also in other studies, the operation frequently requires cardiopulmonary bypass. As you know, if you have the medicinal structure or heart and blood vessel involved, you need cardiopulmonary bypass, but it should not be taken unless you are sure that the complete resection is possible. And it's always represent very complex operations. So morbidity and mortality is very high compared to other surgeries. And there must be medicinal lymph node. There must be no N2 medicinal lymph node involved, because we are talking about N0, N1 in cases of T4. And so these are the very highly selected patients. It is recommended to do a lobectomy, but if the tumor is very high, tumor is involving the hilum, tumor is crossing the fissure, involving both the lobes, then a pneumonectomy sometimes is needed. And 5-year survival rate in one study is 22% by Rami Porta and his team. And now we come to the N2 disease, which is the most controversial in thoracic oncology. N2 involvement represents quite a heterogeneous disease. As you know, there may be N2 which are unforeseen or unexpected, surprise N2 disease. I mean, operatively, before operation, your preoperative workup shows no N2 involvement, but operatively, you find out N2 involvements. This can be one set of patients. Another set of patients has single and multi-level, single or multi-level N2 disease, single bulk multi-level or single and one single level. And finally, there are limited and bulky N2 involvement. So there is advantage of surgical intervention on the condition that a complete resection can be done by performing a lobectomy after induction therapy. So some consider that if you can take a single station N2 disease and take out the lymph nodes and take out the lobe itself, then it has survival benefit. But most of the people are considering downstaging first, and then you go for resectional surgery. So there is one study where it concludes that the most recent meta-analysis, including randomized trials, compares surgery with radiotherapy as local treatment modalities, where they state that no difference in overall and progression-free survival between surgery and radiotherapy in the setting of stage 3 non-small cell carcinoma. So those who promote surgery in N3 disease, most of them, it has been clearly demonstrated that downstaging of medicinal lymph node is a major prognostic factor. So every attempt should be made thoroughly to restage the mediastinum after induction therapy by minimally invasive or other invasive technique, as we have mentioned earlier, and then embarking on a major surgical intervention. And other things, because currently there are many therapeutic options like targeted therapies and immunotherapies. So these new modalities still have to evaluate in randomized phase 2 and phase 3 trials, of course, but optimal combination that provides the best long-term results should come out in a multimodality tumor board discussion. I mean, in all N2 disease, you must have a multimodality, multidisciplinary tumor board discussion. And also, you need a very experienced thoracic surgical team. Now about stage 4A, if, as I mentioned earlier, if there is a single thoracic metastasis like in the brain, you can take out the you can do the metastatectomy, and you also can go for the primary tumor if it fits the tumor size as mentioned earlier. And about small cell carcinoma, there have been findings of a number of recent trials that reconsideration for the role of surgery for the treatment of small cell lung cancer. Although there is still no prospective randomized trials available which have been performed under modern diagnostic and treatment standard, recent guidelines have already adopted the new paradigm and recommend surgery for patients with early stage small cell lung cancer. So as well as adjuvant chemotherapy after first line resection of stage T1 or 2 N0, M0 tumors in case of small cell carcinoma, there are some favorable outcomes in some of the retrospective series. as mentioned in a paper by Takai et Bondo et al. So as I have, I'm driving almost to the end of the presentation here. The surgical resection, the curative surgical resection with curative intent, we have discussed already. Now there are some palliative surgeries. Like one is salvage surgery. Salvage surgery, when you go for chemoradiation and there is recurrence of the lesion and nothing more to offer to the patient, then you can go for salvage surgery. This is a new conception in thoracic oncology, thoracic surgical oncology. So in salvage surgery, you can go for resection, R0 resection, but you have to assess whether you can achieve the R0 resection before going to surgery. Debulking surgery, some of the Chinese studies, they are showing that debulking surgery, I mean taking out most of the tumor but leaving some, has some benefit. I mean, if you give chemoradiation following the surgery, but still I don't know about a randomized control trial or large scale trial. And pleural fluid drainage, actually we do in inoperable cases, advanced cases where there are pleural, massive pleural effusion. We do pleural fluid drainage by tube thoracostomy, which actually, as a surgeon I'm mentioning here, it's an option for the surgery in advanced lung cancer cases. So extensive resection, you can do in most of the cases. We do lobectomy, but if the lesion is a GGO and if the lesion is a carcinoma in situ, we can go for wedge resection and also segmentectomy. Segmentectomy is definitely better than wedge resection, but if you have a solid component, T1A tumor, then you must go for lobectomy. Otherwise, smaller than that, you can go for segmentectomy or wedge resection. And sleeve resection is another idea which has become very popular nowadays. Even you can do sleeve resection by VATS, and you can see if it involves the bronchus or carina, you can always do sleeve. Of course, you need the expertise here. And nowadays, the Chinese surgeons, they also show vascular sleeve resections. The tumor that involves the pulmonary artery, they do a vascular sleeve for the pulmonary artery. Of course, along with all resections, of course, must be accompanied by systematic lymph node dissection and or sampling. So these are the type of surgery, just a small picture here. I mean, lobectomy or segmentectomy or pneumonectomy. So approaches are open thoracotomy or minimally invasive technique, right? Video assisted thoracic surgery, VATS, or robotically assisted thoracic surgery, RAS. So our goals of surgery, as we have discussed along the presentation: removal of the main tumor completely with clear margins, R0 resection, removal of all draining lymph nodes on the ipsilateral side. Some say not removal in all cases. There may be sampling, preserve lung function so that a patient can maintain a good quality of life. So preoperative condition: can an operation be tolerated by the patient, considering other factors? Are there other significant medical problems? Is there sufficient pulmonary reserve? And can the tumor be completely removed? How much lung we can, I mean, we have discussed already, depends on the pulmonary function test and also the general condition of the patient and also comorbidities. Just a few pictures here. How we do thoracotomy, 3-port thoracotomy. This is a picture here, 3-port thoracotomy. We nowadays do single port uniportal VATS, and how the patient is positioned here. These are some of the images of how we use staplers in VATS nowadays. So what do we expect after surgery? Chest tube is typically removed after 2 to 3 days. We put the chest tube on negative suction, and respiratory therapy, breathing exercise, physical therapy, early ambulation, sit out of chair, sit out of bed, and on a chair in day 1. These are all, I mean, expected. Pain control by epidural or intercostal nerve blocks, and along with analgesics. You go home in 2 to 3 days if a successful surgery done. In case of VATS and in case of thoracotomy, need a longer period of time. So in summary, the use of surgery to treat lung cancer depends on the type of lung cancer, the stage of the lung cancer, and overall condition of the patient. Surgery most commonly used when the cancer is confined to the chest and when confined to the lymph nodes on the same site. Lobectomy and removal of all associated lymph nodes is the standard operation when adequate lung function is present. VATS is associated with shorter length of stay and pain. Chest wall resection or pneumonectomy may be required for complete resection. Chemotherapy and or radiation therapy may be needed prior to or after surgery to completely treat the lung cancer. Thank you very much. Thank you all.
Thank you, Shakil. I'm sure we learned many things because we have seen the scenario from the eye of a surgeon. As oncologists, we didn't know anything. I'm sure our colleagues were enlightened from your presentation. Now the floor is open for question answer. Before that, I would like to ask Abhishek and John. Now, Abhishek, as a point of additional interventional radiologist, would you like to make some comments?
First of all, sir, let me thank Professor Islam for an amazing presentation. And as you rightly said, it opens a viewpoint from a surgeon's outlook that how surgery is important. So as an interventional radiologist, I will go by that surgery is always a gold standard, especially in if it is surgical resectable patients. For patients who are not surgical candidates, then we have radiation that is a big player across the world. But also, as of now, across the Western countries, we are seeing, as Dr. Islam had also shown in one of his slides, RF and microwave ablation. I mean, they are the new tools. I would say new kids on the block. Those are coming for small lesions, less than 3 to 5 centimeters, a peripheral lesion, and we can avoid the toxicity, long-term toxicity associated with radiation. So I think that I would just want to add this small point. Otherwise, it was a fantastic presentation, and surgery would always remain a gold standard for resectable lesions.
Thank you, Abhishek. John, would you like to make some of this N2 status, stage 3 N2, the very debatable area where surgery, no surgery, induction, few words?
So I'd say in our MDT for limited, so in our MDT, when we have limited N2 disease, the surgeons will often be very happy to take the patient forward for surgical resection. Undoubtedly, unresectable N2 disease falls within the remit of chemoradiotherapy and ideally adjuvant immunotherapy to follow the Pacific trial protocol, which showed significant improvement in overall survival for these stage 3 patients. I'd say an area of interest that we're seeing now is induction immunotherapy. So we've got several trials running in our center looking at the potential benefits of immunotherapy neoadjuvantly prior to surgery. And in fact, in ESMO 2020 last weekend, there was 2 trials presented which looked at induction either durvalumab or atezolizumab, which did show some improvement in disease response, but probably not as impressive as some of the phase 1 studies we saw using nivolumab. In terms of where the future lies, I wonder whether we may see combination therapy, so the role of induction systemic therapy followed possibly by radiotherapy, and then surgery afterwards followed by perhaps adjuvant IO plus or minus chemo. So it really is an exciting time as we move forward in these actually really complex patients.
Thanks, John. I'm sure I will be coming back to you regarding the question answer session because I have a few more questions to ask you. So now let us go to the question answer session. If I go to the chat box, there is a question from Arman Reza Chaudhary. Arman, would you like to unmute yourself and ask your question? Shakil, I think
you, Kamal bhai.
You can share.
Okay. Thank you, Kamal bhai. I have 2 questions actually. My first question is, what is the importance of pulmonary function test before the surgery? And my second question is regarding mediastinal lymph node sampling or systematic dissection. Which one is actually preferred option? Thank you.
Can you repeat the second question again?
Regarding mediastinal lymph node sampling and systematic dissection, which option is preferred?
Okay, thank you very much for your question. The first question is,
why need pulmonary function test?
Yeah, okay. The first question is, I mean, when you plan for resection of the extent of the lung tissue, like I have showed already, our standard resection is lobectomy. But in smaller cases, in smaller lesions, you can go for segmentectomy or wedge resection. But in some cases, if the lesion involves the hilum or if it crosses the fissure, then you may need to go for pneumonectomy. Now, before doing the surgery, in the pre-surgical workup, we see the lung function test, because we make a measurement of how, and a calculation of how many segments of lung we are going to resect, and what will be the post-operative predicted FEV1 value for the patient here. I mean, I'm talking about spirometry here. Most of the cases we do spirometry in our patients. So if you have FEV1, FEV1 post-operative predicted FEV1 more than 1 liter, you can even go for pneumonectomy in these cases. But if you have, because you are along with the lesion, you are sacrificing functional lung tissue also. So that is the limit for a pneumonectomy. And anything lower than that, if you calculate 18 segments, 10 segments on the right side and 8 segments on the left side, and then calculate how many segments you are going to sacrifice, and then and calculate the post-operative predictive FEV1, and if it is more than 1 liter, then we go for resection and surgery. And regarding the second question, between lymph node sampling and lymph node dissection, I mean, if you, first of all, preoperatively, we make sure there is no N2 disease. I mean, if it is an N2 disease, we discuss it on the tumor board along with the other factors and then decide. But if it is N1 disease, and we know that there are no N2 disease involved, and we have some, or there are some N2 lymph nodes which are not of optimum size. I mean, the size, I mean the size that we consider is more than 1 centimeter. And some of the studies say that more than 1 centimeter is not enough for suspicion. You can suspect in a case of lymph node having more than 1 centimeter diameter, but if it is more than 1.5 centimeter, then it is more likely to be N2. So then, but still then you need the histopathological proof. So during surgery, we prefer lymph node sampling. Lymph node sampling if it is preoperatively established that there is no N2 disease. But if it is highly suspicious, then we go for lymph node dissection, all the lymph node dissection in the N2 areas. And another option is there that you can go for frozen section biopsy. You take out the lymph node first. Before going for operation, you take out the lymph nodes first, the N2 station lymph nodes, and send it for frozen section. If it comes positive, then you may proceed for the surgery if it is a single N2 lymph node and a single station. But other than that, you may abort surgery and then decide sometimes later. I hope I could make it clear.
So there's a question from, so what we understand that when we are doing for a radical surgery, even like radiotherapy, we need to ensure that there is adequate volume remaining, so that doing surgery is not fair enough. We need to ensure that after doing the surgery or we burning the part of the lung, the patient will not struggle. So we need the minimum amount of lung reserve there, which is required to maintain his normal life. Otherwise, surgery will be done or radiation will be done, but the patient will struggle from the inadequate lung reserve. So I think that is the main, and it is not only with the volume, also with the capacity. Sometimes not with the lung volume, but if we say that DLC or FEV1 is required to understand the functional capability, because the patient may be old. So we see a big amount of lung is there, but it is not functioning. So we need to really know the lung function. So the next question is from Dr. Mustafa Aziz Shuman.
Thank you, Shakil sir. My question is particularly for N2 disease, bimodal versus trimodal therapy. Which one you prefer?
Actually, I mean, I don't have that much experience in dealing with N2 diseases, because we don't regularly go for tumor board discussions here in our hospital. But from the study, I can say that trimodal therapy is preferable than the bimodal one. I mean, the long-term outcome is better in trimodal therapy. Yeah.
So you will prefer after induction or radiation therapy, you will prefer for surgery for better outcome.
Right, exactly.
Thank you.
So if I want to add, Shuman, for N2 disease, the main thing is that preferably the surgery should not be done as per NCCN more than 3 centimeter node size. And they are recommending that there should be some neoadjuvant treatment and preferably induction chemotherapy, because they are showing that CTRT is not superior to chemotherapy alone. So they are now preferring more the induction chemotherapy, then assess the response, and then maybe we can go for surgery or chemoradiotherapy. So,
I have a question, Kamal bhai.
yes, Lima.
Yeah. Thank you, Dr. Shakil, for a wonderful presentation. So my first question is, should all the medicinal station be sampled in case of N0 and N1 disease for the adjuvant decision making of radiotherapy?
Yes. If I mean, we prefer if we go for lobectomy and if it is upper lobe, then we prefer to take the subcarinal lymph node in all cases, both in upper lobe and lower lobe. But for upper lobe, we take the subcarinal and the station 2, 4, 5, and 6 on left side and 2, 4 on the right side. So we spare station 8 and 9 in cases of upper lobectomy. But in lower lobectomy, we take the 8 and 9 with subcarinal. So this is like a locoregional lymph node sampling. We don't go for all the stations.
Not for all the stations. And my second question is, what is the ideal number of nodes to be sampled from each station, medicinal station, that will help me in decision making of radiation? So ideal number of lymph nodes. That okay, there is the sampling is quite good. So based on this, I can take my decision, or it is inadequate.
Yeah, exactly. I mean, I cannot state the NCCN guidelines here, but usually we take 1 to 3 nodes from each station.
From each station.
So Lima, if you are,
Thank you for the question.
I ask Riyadh, Altaf Hussain Riyadh, you have a question. So Lima, just let me supplement here. NCCN is telling that sampling is fair enough, not to take serial sampling is fair enough, not to take total lymphadenectomy. Sampling is giving the equal survival. More aggressive surgery is not giving better survival. But as far as I have gone, I have not found the number as you are looking for. Maybe we will find the number. It is a good tool. He has said one.
No. And say in case of breast, in case of breast, we are happy with 10 lymph nodes. In case of colon, we are happy with 15 lymph nodes. So in case of lung, what should be the number that make us happy for decision making?
Probably,
My question was that.
Representative, all the nodal station is more important, probably Lima. But even I also have no answer about it. So maybe we will look for it. If we find, we will share in this forum. Riyadh, you have a question. I think 1, 2, 3 questions.
Yes, sir. Thank you very much, sir, for the nice presentation. I have few questions. My first question is, what is the recommended margin status in case of lobectomy or segmentectomy? Like we prefer 0.5 to 1 centimeter margin for head neck cancer or skin cancer. Like what is the recommended margin in lung cancer, either in lobectomy or segmentectomy? Second question is, what is the definition of adequate pulmonary function? Is it universal for all lung cancer patients, or it is patient to patient variation? It has patient to patient variation.
Okay, thank you for your question. Regarding margin, we always prefer at least 2 centimeter margin from the lesion in all sides. And in cases of lobectomy, I mean, if the lobe is, if the tumor is involving the visceral pleura, there is a T2, whether the size matches or not. But in that case, we take the adjacent portion of the parietal pleura also. So the straight answer is we prefer a 2 centimeter margin in all sides. And the second question is adequate lung function. Actually, it varies person to person. Depending on spirometry results, and also as Kamal sir says, DLCO, and it would be better if we had the ventilation VQ scan here, but we cannot afford that. No. So we depend solely on spirometry, and individually, patient to patient in all ages and sex, you can have the spirometry done, and post-operative predicted spirometry calculation can help you in deciding the extent of lung resection.
Okay, sir. Thank you, sir. I have another question.
Yeah.
Sir, after resection, either lobectomy or segment, either lobectomy, maybe sometimes there is involvement of margin, maybe postoperative histopathology says margin is involved. So it needs postoperative radiotherapy. And we faces very much problem in that case because after surgery, lung expand to its as usual as normal size. So how we should delineate delineate our volume in that case? Which sides or which portion we should consider as margin or which?
Riyad, this is a radiation oncology question. I think let me try to help. Hello?
Yes, sir. I'm listening, sir.
Let me try to help Shakil here. Your question is once the surgery is done, it is inflated. So you don't look at the parenchyma, you go to the bronchus. You find out where was the bronchus they have, what are the level of bronchus they have dissected. And that is your target, not the parenchyma. And once you know that this is the bronchus dissected, then you take margin around that. That will be your postoperative margin area. Could I answer your question?
Yes, sir.
And
thank you, sir.
I can just add, if you do a wedge resection or segmentectomy, then if you see the margin is not clear, actually standard procedure should be doing a frozen section biopsy paraoperatively, so that you can know you get your margin or not. But due to inavailability of facilities here in many centers in Bangladesh, we can go for the surgery, and if you find that the margin is not clear, then if we had used staplers, endostaplers for resection of the wedge or segment, then the endostapler, the metallic pins in the endostapler can be a marker for you to locate the exact site. Or if I take a portion of the pleura, then I may leave a metallic clip there so that later through radiology you can identify the site of the pleural involvement.
Sir, is it used in our country? Or
we can
this
use
metallic clip?
Yeah, metallic clip is the vascular clip that we use in laparoscopy and thoracoscopy. Yeah. The same vascular clip you just can put around the resected margin in the pleura, in the chest wall. It can be easily done.
Okay, sir. Thank you very much.
Thank you.
So, Shakil, our request will be whenever you are doing a surgery, we don't know whether end of the day we are needing a radiation or not. So if you surgeons put a clip there, it is a big help for poor radiation oncologists like us to identify where the dissection was done, and sometimes even where the node was taken out, because sometimes we need to know where to give the radiation. Otherwise, we become blindfolded. So,
I just want to add something regarding this issue.
Yes, Shumon.
Yeah, particularly in post-op lung, we used to treat the bronchial stem. Because
yes.
it is very rare that parenchymal tissue are become positive.
Exactly.
So the post-op target area is bronchial stem and mediastinal nodes. So I am sure that Dr. Riyad might get this answer, that our principal target volume is bronchial stem and mediastinum. So
yes, sir. Thank you.
My request was to our surgeon colleagues that whenever they are taking the cutting the stump, if they can put a clip there, that will be helpful for us. Even in nodal station, like the breast surgery, as Lima was telling, now clip is a big help for us. So this can be helpful for lung. Even we are not very commonly using, but when we use, it is a struggle. Okay, now Debraj, you have a question.
Assalamu alaikum, sir. Thank you for your nice presentation. I had a question that what are the surgeries that are available and practiced in Bangladesh?
What type of thoracic surgery?
Yes.
That you discussed many things. Shakil, what are the common available procedure that is possible in Bangladesh, that is practiced?
Yeah, we actually from very early on we had been doing open thoracotomy for lung cancer. I mean, I am particularly mentioning lung cancer. Lobectomies and pneumonectomies we have been doing for a very long time. Recently, we have started doing minimally invasive video-assisted thoracoscopic surgery. In my training, during my training period in NUH Singapore, I have learned to do uniportal single port beds, which is the most popular technique of VETs nowadays. They have narrowed down the 3 ports to a single port, and all the instruments are going to the single port. So we are doing lobectomies regularly and with lymph node sampling. And for some of the cases, like when you take out a chest wall, portion of the chest wall, in cases of chest wall involvement with portion of 2 or 3 ribs, that we can, in Singapore, I saw that they're doing it through VETs, but here we are still doing it through an open surgery. You take out the lobe and take out portion of the chest wall involving the ribs, including the ribs, and then you put a Prolene mesh or a Gore-Tex Prolene mesh or a Gore-Tex mesh to cover the gap there, to cover for reconstruction of the chest wall. And so that's it. We are doing all kinds of surgery we're doing, but minimally invasive surgery have not been very popular yet because of the expenses and because of the availability of the instruments and staplers. But I'm hopeful that, I've started doing, I'm hopeful that in the next generation, people will be doing these cases more and more.
Thank you, sir.
Thank you, Shakil. So we can say that except robot, you are having everything, maybe not extensively using, but you are doing open and laparoscopic. Both the
thoracoscopic, yes, sir.
Thoracoscopic, but endoscopic surgery you are doing. Maybe gradually the field will expand and you will be doing bigger and bigger, more and more surgery. Yes. So I think there is a question for Dr. Istisfar Hussain from Sylhet.
Assalamu alaikum.
Walaikum assalam.
Thanks, speaker, for nice deliberation. We know that there is a major controversy in doing surgery, especially for stage 3A. My asking, can you do surgery in non-bulky and 2 disease, that is 3 centimeter or less than 3 centimeter nodal disease? Regarding lymph node resection, at least 6 lymph node removed during surgical resection, 3 from N1 and 3 from N2 station, I think so. Thank you.
Okay, as I have mentioned earlier, N2, stage 3A, we have categorized stage 3A in different situations, like T3N1, then T4N0N1. So in these cases, you can do extensive surgery if it is if we can achieve R0 resection. And in cases of N2 diseases, yes, if it is a single station, non-bulky, we can go for. I always prefer doing induction chemotherapy or chemoradiation first, neoadjuvant chemoradiation. But if you have to go for surgery or there is a surprise N2, like you open up knowing that there is no N2, but per-operative you find the N2, then you take out the lymph node of that station and also the other stations. Number of lymph nodes, I haven't come across the papers as I have mentioned earlier, or I don't know the NCCN guidelines about this, but number of lymph nodes, I think, the stations are more important, I guess. You have to cover all the stations, station 7, 5, 6, 2 and 4 in cases of left side, and also 2, 4, and 7 in cases of right side. Upper lobe. And if it's lower lobe, then you take out the station 8 and 9 nodes also. Of course, with your lobe, you take out all the N1 lymph nodes, which are accessible.
Yeah. Arman, I think you have a question to John.
Yeah, thank you. I have a question to Dr. John, that regarding survival benefit, is there any difference between neoadjuvant chemotherapy or adjuvant chemotherapy in case of early stage lung cancer?
So the meta-analysis of adjuvant chemotherapy showed a small 4 to 6% benefit from adjuvant chemo in patients with node positive, big tumors, lymphovascular, so specific risk features. In terms of neoadjuvant chemotherapy, we haven't yet seen any clear advantage in terms of survival. So in terms of where we use it, I would say in select patients is where there's a feeling that neoadjuvant chemotherapy may facilitate the surgeon to be able to perform a more limited operation. But again, in our centre, we're quite keen to enrol those patients in neoadjuvant treatment trials, because it goes beyond just standard platinum-based chemo to include typically immunotherapy. And so it's an opportunity to essentially look for better neoadjuvant combinations.
Okay, John, let me ask you a question. What about what your comment about this very famous adjuvant osimertinib after the surgery? That was a big noise in the last ASCO.
Yeah, so it showed in disease-free survival improvement, didn't it, at 3 years? I must say, so they didn't show any overall survival data yet. That's still yet to mature. The question, of course, is, are you just delaying the recurrence of disease once it becomes resistant to osimertinib, and therefore you've spent a considerable amount of money on osimertinib for 3 years, which many health economics wouldn't be able to afford given the cost of osimertinib. So I'm a little bit more reserved. I prefer to see that there is an overall survival benefit demonstrated eventually from adjuvant osimertinib.
Thanks, John. So yeah, sorry.
And another one that came out interestingly last weekend was the results of the lung art study. So adjuvant radiotherapy in resected N2 disease. So again, I think that was an important trial as it demonstrated that adjuvant radiotherapy doesn't seem to improve outcome in patients. Yeah. And in fact, because of radiotherapy, there does seem to be some potential increase in death due to cardiac late morbidity. So again, important practice-changing data, I think.
Are you going to stop radiation adjuvant, John, with the trial?
So I was never a big fan in the first place, I have to be honest. So the only time I really consider using it routinely is in patients with resected disease, which demonstrates extracapsular spread. So going back to my head and neck days many years ago, you know, if you've got extracapsular spread, then I do feel that there's a risk of microscopic residual disease. So I do consider it for those patients, but I don't normally do routine post-op radiotherapy for unexpected N2 resected disease. My feeling is these days, because we have such good potential radiotherapy we can use, you know, to keep a close eye and, if necessary, give salvage radiotherapy on the signs of relapse later on down the line, maybe even stereotactic radiotherapy if they've got single nodal site relapse. So,
thanks, John. So I think I would invite, in the chat box, I don't see much question, but you are welcome to ask any question. Anybody, you can just unmute yourself and ask the question. We can take 1, 2 more questions if anybody is interested. Okay, I'm assuming there is no question, so we are moving to our next session, that is our case discussion. Just for everybody's information, that we have updated the data of our bonus point, and we found 3 candidates: Debraj Chakraborty, Dr. Sonia, and Dr. Altaf Hussain Riyad has achieved 100 bonus. Congratulations to all 3 of you. You will be awarded for this achieving 100 bonus, and again you will start from 0 because this will be discarded from your list. So you will start from the ground again. So I will appreciate that everybody should try to participate in this case discussion and rapid fire session, because every participation will give you a bonus point, and end of the day 100 bonus will give you a reward. So congratulations to Riyad, Debraj, and Sonia. And today we are going to start our case discussion. So who will be the volunteer today? Anybody? No volunteer. After declaring the award, I was thinking that there will be more candidates. So if I look at the name, let me randomly pick. What about Suryana Sultan? Are you there? Or Tasneem Hussain?
Yes, sir.
Okay, are you there?
Welcome, sir. Yes, sir, I'm there.
Okay, Tasneem. So let us start the case. It is a 50 years old man, smoker 10 pack years. While doing his routine medical checkup, a shadow was seen on the right upper side of his X-ray chest, which did not respond to antibiotic. Then chest CT was done and a 3 centimeter lesion was seen on the right upper lobe without any lymph node. Now question is, what you will do next? There is a no lymph node, 3 centimeter, single lesion, right upper lobe, 50 years old, smoker, smoking history, and that's all.
Yes, sir.
What you will do? Will you do some workup? You will do for some investigations?
Yes, sir. I want to do some further investigations. Sir, I want to do bronchoscopy. And sir, I want to, I also want to see the histopathology of the lesion.
Okay.
So, sir, I want to do.
Histopathology. Anything else?
Yes, sir. With bronchoscopy, I can also go for, sir, bronchoalveolar lavage, and if it is if there is productive cough, I can also do sputum for cytology, and
Okay, so
sir,
you have say we have done the biopsy. We found it is a lung cancer.
yes, sir.
So you can see that we need to see the age is a factor. Smoking history, we know he is a smoker. We need to know whether there was any family history. We need to know the occupational exposure. We need to know whether there is any pulmonary comorbidity or cardiac comorbidity, whether there is any exposure history. And radiologically, we need to know the size and shape and the location. And we need to do a PET-CT for distant metastatic workup. So, and we need to know that if it is a very small nodule, NCCN is telling that we need to categorize that in low risk group and high risk group. So low risk group is minimal or absent of history of smoking or other risk factor, and high risk group is mainly smoking history, or if there is a history of lung cancer as a first degree relative exposure to asbestos, radon, or uranium. So these are the issues that normally they are recommending. So CT guided fine needle aspiration biopsy was done and it revealed non-small cell lung cancer, adenocarcinoma. So what do you want to do now? Now we know it is a 3 centimeter lung cancer, adenocarcinoma, right upper lobe, single lobe lesion. Only we have done a CT scan. Do you like to do any more imaging? Tasneem. Just we discussed what imaging we want to do.
Sir, I can do a PET CT scan.
Yes. We do a PET CT scan. Anything else you want to do? Okay. See that if it is a stage 1A, then we need to do the pulmonary function test, bronchoscopy already you said, and we need to do the PET CT. But when it is a stage 1B, then we need to consider brain MRI and 1B to above, along with the other investigation. And in case of adenocarcinoma, even in stage 1A, some center practice brain MRI when they are going for radical treatment like surgery on SBRT, because they don't want a surprise, because adeno have a high prediction of brain metastasis. So the PET CT and brain MRI was done. There is no nodal involvement and there no distant metastasis. So the clinically it is CT2N0M0. So in MDT, what treatment will you recommend? You are in the MDT, surgery, radiotherapy, chemotherapy, immunotherapy, chemoradiotherapy. What do you will go?
Sir, I can consider for surgery, sir.
Yes, thank you. So this is a publication in Chest article. They have shown that for stage 1 and 2, lobectomy or greater resection remains the preferred approach and giving the better survival. So till now, even being oncologist, we agree that surgery is the best outcome modality if possible in stage 1 and 2 disease. So MDD discussed the case and finally recommended for surgery. So somebody asked, can you do a RFA to this case without doing a surgery? Well, it is a, if we look at the size, it was a T2 disease.
Yes, sir.
T2 disease, will you do a RFA? So rather ask me, do you know, is there any limitation of size for RFA? Can you do RFA for any size of lesion?
Sorry, sir, I don't have any idea.
Okay. So again, we take this guideline publication from CHEST 2013. They are telling that RFA is recommended for effective in medically inoperable patient with a small, that is less than 3 centimeter peripheral non-small cell lung cancer. They are not recommending RFA for non-small cell lung cancer when the lesion is more than 3 centimeter. Many centers do it, but the recommendation is within 3 centimeter. So if the tumor involves the chest wall, or if it is superior sulcus tumor, then will you advise surgery? Because now it is not a tumor at all. It is invading the chest wall. It is invading the, the superior sulcus tumor. Sometimes it has taken the rib. So will you go for surgery, or you go for any other modality? Tasneem?
Sir, after neoadjuvant chemotherapy, surgery, review for surgery can be done, sir.
So carefully selected patient of these, yes, you are correct, in superior sulcus, we need to give chemoradiotherapy, neoadjuvant, then we can go for surgery. But the message is upfront or adjuvant surgery is a good modality for chest wall invasion and also for superior sulcus tumor. This invasion or involvement is not a classical contraindication for surgery. So surgery was done. Now, what is the factor that you will consider for deciding the adjuvant treatment?
Sir, the factors are R0, if R0 resection was possible,
okay,
and if any node was positive.
Good.
Sir,
I think you have covered most of the thing. Majority is the margin, and then whether there was involvement of the nodal status and staging. Higher the stage, more the adjuvant. From observation up to chemoradiotherapy, the question is whether we give chemotherapy alone or chemoradiotherapy. When we give chemoradiotherapy, whether we give sequential and concurrent. This is a huge, busy chart. We can look into it, but as you mentioned, it's correct. The best thing is to get a R0 resection, which Dr. Shakil was repeatedly telling, and then according to the stage and the margin status, we can decide whether we give adjuvant treatment with radiotherapy, chemotherapy, or both, either in combination or sequential. Okay, the patient was offered thoracoscopic lobectomy against open lobectomy, but he was scared to get an inferior outcome of thoracoscopic lobectomy. So what will be your opinion in this case? That is a small lesion. Dr. Shakil is telling, I can do a thoracoscopic lobectomy. The patient is telling, no, if you don't do an open lobectomy, I may get an inferior outcome. What do you think? Will there be any difference?
yes, sir. In thoracoscopic lobectomy, hospital stay is relatively shorter, and so there is also less complication related to it.
Survival testing. I agree. Thoracoscopic is a better option because less stay, less cost. I mean, quick recovery, less complication. But will there be any? He's scared that whether the outcome is equal, survival is equal or not.
Yes, sir. The outcome is almost equal.
Equal. Yes. It is a big trial done in USA, 1,000+ patient Z00330 trial, and they have done the randomization on size and used beds and open lobectomy, and then they have found the overall and DFS differs between T1 and T2, but when they have compared the procedure, beds versus open, they have found that neither the OS nor the DFS, there was any significant difference. So patient is interested to go abroad to get a robotic surgery done, because in Bangladesh, there is no robot. And he believes that robotic surgery can give him a better survival. What do you think about it? Can robot do better in survival?
No, sir. The survival outcome is similar, sir.
Good. Still now, this is a systemic review, and they have shown that robot is not doing better in survival compared to our conventional surgery. So still robot could not beat human. So now the patient, the situation is a bit different. Same patient, but it is cardiac function is only 25% ejection fraction. The anesthetist is not ready to do a anesthesia. So Shakil cannot do a surgery. But the patient wants something similar to surgery. Do you have any option in your hand, Taslim, that you can offer this patient, 50 years old young man, but unfortunately cannot go for surgery or is not ready to go for surgery, but he needs something equal to surgery or near to surgery. Can you offer him some option, Taslim?
Sir, SBRT can be offered to this patient.
Wonderful. Yes. So Robert Timmerman, who is a pioneer on this SBRT promotion for early stage lung cancer from Stanford University, they have shown that the 3-year survival data was 55.8% with a local control of 90% plus, which is comparable to surgery. And from there, many other studies have established now that it is a almost equal, but not the replacement of surgery yet, because no head-to-head trial is there. And we will have more discussion on it on next week. Okay, so now the patient is no more a stage 1 T2 disease. Now it is a stage T3, stage 3A and 2 disease. And diagnosis we have confirmed by EVAS. So will you agree for surgery after neoadjuvant CTRT if the surgeon colleague recommend in the tumor board, or do you want to continue CTRT? CTRT done, good response. So partial, and then the Shakil is interested to do a surgery, and Dr. Shumo is interested to continue CTRT. What will be your recommendation? Okay. So this is a trial published in Lancet. They have done, they have made 2 arms after CTRT, and they have seen that continuation of CTRT and surgery, and then they have found that CTRT arm was doing slightly better in PFS, but in OS there was no difference. And another study by URTC, they have done unresectable patient, they have done induction chemotherapy 3 cycle, and then they have allocated the patient for radiotherapy and surgery, and they have found no difference between DFS and OS. So as a radiation oncologist, you can become biased towards CTRT or RT without compromising the outcome. But yes, surgery can also be done. So do you think radiotherapy to chemotherapy as induction gives additional benefit in stage 3A and 2 disease? Or only chemotherapy induction is fair enough?
Adding radiotherapy gives some additional benefit. Okay,
unfortunately, we cannot agree with you at this moment. Maybe in future something will happen. That this is a meta-analysis done by Asad A. et al. And they have taken initially 302,077 studies from PubMed, but finally they could only analyze 4 and 3 randomized control and retrospective studies. And these are the studies. And then finally they have found addition of chemotherapy with radiotherapy in neoadjuvant setup for in stage 3 and 2 disease is not giving any additional benefit. So that was all, and thank you very much, Taslim. You have done wonderful job, and congratulations. I'm sure Samir will put bonus to your account. Very good. Thank you very much. So now we go to the quiz. Samir, can you please put the link of quiz in the chat box? It is given. The quiz is already, quiz link is given. Anybody can now try. Open for everybody. So during this period, whoever we can have some discussion that Shakil, what is your experience with the surgery of advanced stage? I mean, like stage 3 or 2B type of disease. Are you getting frequent cases in our country like that?
Yeah, thank you, sir. Yeah, actually, previously, as I have experienced during my student life during the period I was in the final stage of MS course in NIDCH, I saw my professors, and also some of them are practicing now. They used to do a lot of debulking surgeries. I remember very few cases that they had done preoperative staging or preoperative mapping of the medicinal nodes before going to surgery. So they would see a lesion, and there is no involvement of the carina on bronchoscopy, and there is no effusion. They usually went for surgery, and sometimes they did debulking surgeries. But nowadays, in my practice, if I see a N2 station lymph node, I always send the patient for reassessment and evaluation of that N2 lymph node. So definitely, my thinking has changed a lot, probably because of my training in Singapore. And so nowadays, I'm very choosy about the resectional surgeries. Any I refer to the oncologist, or because we don't have a tumor board in our hospital, so I refer to the oncologist, or I try to take the sample by any means to see whether this N2 station lymph node is really involved or not. So I think that's a big change, because previously I also used to do cases like we would go for pneumonectomy for a small case.
That I wanted to hear. Now I want to hear from Abhishek. What is the frequency of early stage lung cancer you are getting in your center, Abhishek?
As Dr. Shakil also said, sir, probably in the South Asian subcontinent, we don't have that lung cancer screening protocols in place. So till that we have that, the diseases that we get, they're all large, bulky masses with lymph nodal involvement, upfront metastases. I think going by the data that we are seeing with the low dose CT chest for high risk population, it is really adding on to the survival advantage. I think that's the way forward, that I think we should implement it in our countries as well. And so that we can pick up early small cancers and really make a survival difference to these patients. So I think once we start doing that, then there will be more patients going for surgery, more patients going for SBRT, more patients going for even ablation as well.
Thanks. John, what about your experience in your country? Are you running a low dose CT screening in your country?
Yeah, so we've got, nodal CT screening, or so we've kind of taken on a similar Nelson trial. So we're running that in North and Northeast London, and essentially what we're beginning to see is picking up a lot more early stage disease, which means that our surgeons are doing a lot more RAT type procedures, which is good. Does that answer your question?
Yep. So my next question is, in your country, what is the percentage of patients fit for surgery but opting for SBRT?
I would say very low. So in fact, Barts, where I work, has the highest surgical resection rate. So we've got 44% surgical resection rate, which is above the sort of English average. In terms of the number who decline surgery, very few, you know. I would say 10%, it would seem. The surgeons I work with are all VATS, RATs, sort of minimally invasive surgeons. So, and I think patients obviously are attracted by that.
So it's interesting. I mean, because, you know, in Netherlands, they are getting more patients switching from surgery to SBRT, and they have published a good number of patients data that switching from not going for surgery, going to SBRT. So it is actually, I think, cultural, and the surgeons and many issues are there. So about the this advanced disease, I mean, in your MDT, are you more keen to go for CTRT or going for neoadjuvant followed by surgery? I mean, going for single modality or trimodality? Dual modality or trimodality?
I think we will. I think we use more chemoradiotherapy and then possibly adjuvant immunotherapy if they're PD-L1 positive. So in the UK, the EMA restricted our use of adjuvant durvalumab to only PD-L1 positive patients. And of course, internationally, the original Pacific trial wasn't looking at PD-L1 expression and positive or negative. It was an all-comer study, but the EMA, for whatever reason, their wisdom was to, because it didn't show benefit in an unplanned analysis in the PD-L1 negatives, they've said we can only treat patients who are 1% or more, or in fact, where there's insufficient sample to determine their PD-L1. So that's normally, I would say, our approach, is we go with chemo-rad-IO.
So are you practicing adjuvant durvalumab regularly?
We are, yes, yeah. We're using it frequently. And in fact, again, last weekend, the ESMO, they presented their 4-year survival data for the Pacific, and it's persistent survival advantage, PFS and OS, so, which is great.
Okay. So now we are going for our next question, that is the rapid fire. So who will be the volunteer? I was mentioning Tasneem and then maybe Nausheen or Suryana, I don't know, but you are always welcome. Suryana, are you there?
Yes, sir. Assalamualaikum, sir.
Walaikum assalam. So are you ready?
Okay, sir.
Okay. So what are the high risk factors to be considered in incidental pulmonary nodule evaluation? We discussed in the NCCN guideline at the bottom, if you remember, what is the most important high risk factor? If there is a pulmonary nodule, what is the most important high risk factor that we should consider? What habit?
Smoking.
Smoking, yes. History of lung cancer in a first degree relative, exposure to asbestos, radon or uranium. So when you will do MRI of brain as part of evaluation in early stage non-small cell lung cancer, in which stage?
It's 1B.
1B.
And above.
Right. In 1B and above, we should do brain MRI. So what is the maximum size recommended for RFA in non-small cell lung cancer? As per
less than 3 centimeter.
Yes, it is maximum. Yes, you are correct. Less than 3 centimeter, maximum is the chest. What is the difference of treatment outcome between thoracoscopic lobectomy against open lobectomy?
No, there is no overall survival benefit.
Exactly. So this Z0030 trial, that is Alliance trial, showed that there is no proven treatment outcome benefit between thoracoscopic lobectomy against open lobectomy. So what is the superiority of robot-assisted lobectomy over conventional endoscopic surgery?
No benefits. No
yes.
superior.
Till now, no data to support superiority of robot-assisted lobectomy over conventional endoscopic surgery. Okay, so who is the pioneer to prove the role of SBRT for early stage non-small cell lung cancer with comparable to surgery outcome in medically not fit for surgery patients? Who is the person? Can you tell the name?
Sorry, sir, I forgot.
His name is Robert Timmerman of Stanford University. He is the father of SBRT or lung cancer. And he has shown with his small series of patients that 3-year survival was 55.8%, which is fairly comparable with surgery data. What is the role of surgery after neoadjuvant in stage 3A and 2 disease? Is there any role?
Yes, sir.
Yes. In Lancet, they have shown that we can do a surgery, but it is equal to CTRT. But in URTC, they have shown that after induction, we can do surgery, but we can also do CTRT. So surgery have a role, but we have an option of CTRT. So what is the benefit of addition of radiotherapy to chemotherapy in neoadjuvant setup in stage 3 into a non-small cell lung cancer? Or may I ask, is there any benefit of chemotherapy?
No, sir, there is no adding benefit.
Yes, this meta-analysis of Assad et al. Have shown that addition of radiotherapy or chemotherapy in neoadjuvant setup does not show any survival benefit of stage 3 into non-small cell lung cancer. So thank you very much, Suryana. Wonderful, you have done great job. Now, if our academic partner is Roche, and I request if there is any representative of Roche, would you like to say very quick vote of thanks? Anybody from Roche?
Thank you, sir. Thank you for the collaboration, and I'm very much thankful to all the faculties and all the participants for discussing so many important topics in lung cancer and the role of surgery. I'm hopeful that all the participants and the faculties will be benefited from this discussion, and hope that new topics will be discussed in the upcoming webinar sessions. And best of luck. Thank you so much.
Thank you, Shafiq. Thank you for your support, and we hope this support will continue. Before declaring the quiz, I want to share with you a great news. Tomorrow is a day when our mentor, our president, will be celebrating his happy birthday. So let us all wish him a prosperous life, and we want to celebrate his 100th birthday in some platform of Oncology Club, and may Allah bless him with all his kindness so that we enjoy his presence and his all type of support to us. Now, if we go to the, today's winner. So today's winner is Dr. There is two person who scored 100, but unfortunately, through timing, Dr. Samia was the first to score 100. Dr. Altaf Hussain Riyar also scored 100, but he could not be treated as the winner because he was the second person to submit. Congratulations to Dr. Samia. So,
thank you, sir.
Samia Wahid.
Yes, sir.
Can you please show your, open your screen so that we can see who is Dr. Samia? So next week we will be talking about role of SBRT. I will be talking, and we will have a great faculty with us. Dr. J.P. Agarwal from Tata Memorial Hospital will be with us. John will be there, Ullas will be there, and I wish Abhishek, if you can be with us. So we are almost at the end. Now, I think, where is Dr. Samia? Could we meet her? Yes, there is Dr. Samia Wahid. So congratulations, Samia. You unmute yourself, where you are working.
Sir, I am currently working at NICRH as FCPS second part trainee. Sir, I was the first trainer at United Hospital Limited in radiotherapy.
Okay, so my ex-colleague in United now working in.
Sir, you used to ask several questions in every day.
Okay, so you left United for me because I asked so many questions.
No, sir. After competition, my training, I left there.
Be doing good, become always first, and hopefully we will be enjoying the same session next week. And thanks to John, Abhishek, and all our participants, special thanks to Dr. Shakil. So now I request our President, Professor Heiser, to officially conclude the session, sir.
Okay, thank you, Kamal. Thank you very much for everybody for for offering me Lord Davis. Our today's session was very nice. My thanks to Saiful for his nice lecture. Has covered almost all the aspects of surgery, surgical management, and also the other faculties who took part in the discussion. So without delay, I think we are running short over time. So goodbye, everybody. Assalamu alaikum wa rahmatullah.
Thank you, sir. We are only 2 minutes late, sir. We are on schedule. So thanks to all and see you next week. Allah Hafiz.
Advanced happy birthday, sir.
Walaikum assalam, sir. Thank you very much.
Happy
Assalamualaikum, sir. Happy birthday, sir.
Happy birthday, sir.
Invitation.
Happy birthday, sir.
Nice to meet you all.
Assalamualaikum, sir.
One day advance. Who is the birthday? Advance happy birthday, sir.
Advance happy birthday, sir.
Thank you.
So I'm ending the session.
Okay.
Okay. Allah Hafiz, everybody.